welcome to Brain Chat. I'm Dr. Mitzi Joy Williams, your board-certified neurologist and MS specialist, and my mission is to engage, educate, and empower those affected by MS to become an active part of their healthcare team. Here on Brain Chat, we'll be discussing all things MS, health and wellness, advocacy, and we'll even throw a little bit of music and music therapy in there as well. Thank you so much for joining us, and stay tuned for the next episode. Happy Monday and welcome to Brain Chat. It's Dr. Mitzi, your board certified neurologist, MS doc. And I am so excited to talk to you about a topic that's very important to many of the people that I see and have treated throughout my career. And that is fatigue. And, one of the things about fatigue with MS is that it's not your run of the mill fatigue. So we just had a big conference last week called the Consortium of MS Centers, where we learned so much about many of the new research ideas as well as new medications coming out for MS. And Dr. Mitzi is a little fatigued, but MS fatigue is very distinct from your run of the mill, I'm tired because I was running last week type of fatigue. And I've got two experts that are coming to talk with us about it. You know what we do when we first start Brain Chat? Just log in, type in the chat where you are logging in from. I bid you greetings from Atlanta, Georgia, where it is warm and sunny, but it was warmer in Washington, D.C. last week when I was there. All right, so you guys know how we do. Just tell me where you're logging in from, and we will get ready to bring up these amazing guests. So first, I am going to introduce Dr. Jacque Nolan. She's a board-certified neurologist, and she works with Tanner Multiple Sclerosis Center and Tanner Neurology in Villa Rica, Georgia. So we are neighbors here in Georgia. She earned her medical degree from the Georgia campus of the Philadelphia College of Osteopathic Medicine and her master's in public health from Emory University. She completed her neurology residency at Grandview Medical Center in Dayton, Ohio, and a MS-focused fellowship in neuroimmunology and spasticity at Riverside Methodist Hospital in Columbus, Ohio. And we're welcoming back Dr. Katil Ramahan. So he was with us not too long ago, but as promised, he's back to talk about some amazing research with fatigue. And he has quite an impressive bio, but I'll get some of the highlights here. He's a professor of neurology, clinical, and the director of the Multiple Sclerosis Center at the University of Miami in Miami, Florida. He's board certified by the American Board of Internal Medicine and the American Board of Psychiatry and Neurology with a special competence in neurology. He has served on the National Multiple Sclerosis Society as a member of the Medical Advisory Board and Clinical Care Committee and chaired the Clinical Advisory Committee at the national level. He is recognized for his support of MS with several honors, including the Hope Award, the Spirit Award, Outstanding Physician Recognition Award, and Researcher of the Year in 2019 for his vision in starting a database in MS national in scope called the North American Registry for Care and Research in Multiple Sclerosis. Welcome, Dr. Nolan and Dr. Ramahan. Welcome to Brain Chat.
Hello.
Good to be here. Thank you.
Okay. Awesome. Thank you guys so much for spending time on your Monday night. I know we're coming off of a busy conference last week, the Consortium of MS Centers. So before we get started, and I see we got some people viewing from Macon, Georgia. We also have someone viewing from Virginia and Chicago, my old stomping ground, my hometown where I was born. All right. Thank you guys for logging in. So before we get started, can we just say, or can each of you share maybe one takeaway that you got from the Consortium of MS Centers before we start talking about fatigue?
Absolutely. I guess I'll start first. The week was full of talking about diversity in MS for me. And I know, Dr. Mitzi, you were very involved with those discussions. You led those discussions. Thank you again for allowing me to do a presentation and discuss that. But the biggest take home that I want to talk about briefly is MS in Black people, African Americans, where originally or kind of previously this was thought to be kind of nothing that we didn't typically see in our community, our Black community. But we now know with recent data that is continuing to come out and showing the same things where the incidents are, so the number of new cases of MS as well as the number of existing cases of MS in Black people is almost equal to what we're seeing in white people in the United States. So that was a huge take home message for me.
Absolutely, and so, one of the challenges with understanding MS in certain populations is that we have not traditionally had a lot of research and data to help us understand. But as, groups like the MS Society and also large databases such as the Kaiser Permanente group are, publishing some of their data, we're finding out more and more about the actual composition of MS in the United States. So it's very exciting. And I look forward to, more research that's coming down the pipeline. What about you, Dr. Ramahan?
Well, it was a really, really good meeting, and it was great to be actually back in person. We have had a lull of a couple of years because of this COVID pandemic that's been going around. And in October of last year, we had the first in-person meeting of the CMSE. That was sort of a teaser, half hybrid and half in person. And this one was a complete in-person meeting, about 1,100 plus people. And it was really, really good to catch up with old friends and colleagues and actually chat one-on-one with a number of really invested investigators. And there were so many things, so many sessions that were exceptional. But I would say, you asked for one takeaway, and it's kind of hard to pinpoint, but there was one study that all of us had heard about that, for the first time, the results were announced. And that was the DISCO-MS study, which is discontinuation of MS therapies. And this was in the late-breaking news. And we had always wondered about it and sometimes even practiced it without any data. The single question they were asking is, once you start a disease-modifying therapy, do we have to continue it ad nauseum? Do you continue it till the end of the person's life? And the prevailing wisdom, as you know, is you don't, why mess with something that's working? If it is working, don't mess with it, don't break it. Just keep doing it. So there are people who are taking self-injected interferons, Copaxone, and a number of the early injectables from the time they got started and to this day for 20 years. And did they really need to do that? And this was a study aimed at asking that question. And there is some evidence coming out of what is known as immune senescence. Namely, as we get older, the immune system becomes less and less aggressive. And autoimmune disorders sort of normally tend to subside in the older population. So why keep suppressing the immune system on top of that? And a very important study, John Corboy was leading the effort. It was a study that was funded by PCORI, Patient-Centered Outcome Research Institute. PCORI funded it. And without making it into a long story, the long and short of it was, when they randomly divided the patients into a group staying on their therapy and a group going off their therapy in a population which was 55 years and older, what they basically found was that the relapse rates were slightly higher when you go off, but only 7.8% more. And so, the yield from staying on the disease-modifying agent becomes really tiny. And the progression is the same in the two groups, whether you stop it or you don't stop it. This is a very important study. And of course, it's not long enough at this point, and those patients are continuing to be followed. So I think it'll be interesting to hear more from John in the coming conferences as to what happened to this population, because they are continuing to be followed. We need guidance at this point in terms of what to do with these patients that you have started on treatment. And I think a time may come when we may decide that, it is possible to go into what is called as, drug-free remission. And I think that's sort of the holy grail. We all want to get to that point where you don't want to keep on blocking and suppressing the immune system because it has its consequences that are not as desirable. So, yes, it was a great meeting. It was
Yeah.
a great meeting in more ways than one, and lots of takeaways. But this is what I took away from that.
Yeah. Yeah, both awesome takeaways. And I love attending our congresses and our conferences because even if it's information that I feel like I've heard before in some form, I always seem to take away something new, and I think that we're getting to the core of answering many questions that can really help us, determine the best way to treat people living with MS. Now that we have more high efficacy treatments, we always have to weigh the risk versus the benefits. And we certainly always want the benefits to outweigh the risk to that individual person. So let's switch gears a little bit and talk about symptomatic management. And let's go to our topic tonight, fatigue. So I really wanted to do a show on fatigue because it is one of those silent symptoms of MS that can be extremely disabling. And I spend a lot of time educating my patients about fatigue specific to MS, as well as educating their families, because sometimes it's one of those symptoms where family members could feel like, that person's being lazy or that they just don't want to do things and they don't really recognize that fatigue can be a symptom of MS. So first, let's start by talking about what is MS fatigue.
So, shall I go first?
Yes, feel free.
Yep. So, there isn't a single person on this call who has not experienced fatigue because it is a normal and a natural phenomenon. And it is a phenomenon where, we wake up in the morning with recharged batteries, so to speak, and we go like an Energizer bunny the rest of the day, and the charge sort of peters out towards the end of the day, and we are tired, and we go to bed, and we recharge, and this cycle continues. And this is the normal circadian rhythm that has a cycle built into night and day for us non-nocturnal creatures. This is a normal phenomenon, just like you started this show saying that you had an exhausting CMSC meeting, you are fatigued and you're tired. It's common, it's natural. When this becomes unnatural is when you wake up in the morning not recharged, but you're ready to hit the sack again, go back to bed. You wake up in the morning and you're not ready to get going. And I know we all have had those moments when we don't really want to get up, you want to go back to sleep. That's not what we are talking about. We're talking about somebody who has had a full night's sleep and doesn't still feel rested and recharged. And this situation where the batteries are depleted, so to speak, at all times, and that's an abnormal state. And often mistaken, as you just said, for this person is lazy. This person doesn't have the drive, does not have what it takes to be successful, what it takes to be, to put in a hard day's work. Instead, this person is lazy. And it is particularly, unfortunately, true that the level of fatigue does not have to correlate with the level of physical impairment, which makes it even harder for a person because, when somebody is paraplegic, quadriplegic, or, have significant motor impairment, it is almost like that individual has a reason why he or she cannot go back to work. But I have, as also Dr. Nolan, and as also you, have seen patients who are paraplegic, who are in a wheelchair, putting in a full day's work with really no problem. If you can make the accommodations for them, they are at work at 8 a.m., they put in a full day's work as anybody else in that office, and they get home and they enjoy the leisures that are common to anybody and everybody. But that's not what we are talking about. This is the person who's not having significant physical impairment, but yet has exhaustion, completely wiped out. and the person is unable to think straight and unable to do the things that would normally take a fraction of a time for somebody who's healthy and not fatigued to do. And it spills over into other things, including especially cognition. And
Mm-hmm.
this is very common, cognitive impairment and fatigue, to be seen in the same person, or it can be separate. And treating fatigue, and we'll get to the treatment, treating fatigue will help fatigue, but not necessarily help cognition. They are independent, what we call silent symptoms, but really are not silent. You talked earlier about NARCRIMS, the North American Registry for Care and Research in MS. It's something near and dear to me. It is one of the things I talked about at the CMSC was one of the abstracts that we had presented from the findings of NARCRIMS. We have a part of NARCRIMS called Health Economic Outcome Research. And it was a simple study that we did. It was about 800 subjects. Right now, NARCRIMS has 980 subjects. It's going towards its 1,000 mark very shortly. But in the 800 plus subjects, when we looked at their enrollment visit, in terms of their in terms of their employment status, what we found was that the majority of the people were employed, and this was a relatively early, mildly affected population because we chose to study that kind of a group of MS patients because we wanted to study the early patients, because this is a longitudinal registry where we want to study what happens to these individuals over a period of time. So the inclusion-exclusion criteria was such that we recruited early MS patients. And when we queried in this group of early MS patients, what we found was about 15% of them were unemployed. But more importantly, almost a third of the people were underemployed. Underemployed. They could not quite achieve their full potential at work. And when you queried them, what was the cause for your underemployment? Number one was fatigue,
Fatigue.
prevented me from working a full day. Number two was cognition. And
Mm.
the average number of hours missed in a week because of fatigue was 7.5 hours.
Wow.
So it's almost like they missed a whole day out of the week
Right.
because of the symptom of fatigue. So its impact is huge.
Right.
And this also translated into their household activity. We are not just talking about inability to work. People came home, did not do their chores because it was too much to do. They were exhausted when they came home. They were exhausted when they went to work. And they didn't have the energy to do the laundry, to do the cooking, to
Right.
do the cleaning, and all the things that is automatically and commonly done by someone who is not that afflicted with fatigue. So,
Right.
let
You
me
know,
stop
and
there. Yeah.
yeah, and that was one of the reasons that I really wanted to address this topic, because it is far reaching, right? So it's not just about the person's ability to work, but also their interaction in their daily household with their families, with their children, etc. And in many cases, if they are able to work, by the time they get home, they've exhausted all of the energy for the day. So they're done. Now the other thing is, we don't necessarily have a specific, let's say, spot or center in the brain that we can say causes fatigue in our patients. And I think one of the other issues that we often see is that there are many other things that can contribute to fatigue related to MS. Some of those secondary causes, like if they're having difficulty sleeping. Dr. Nolan, can you talk a little bit about some of those secondary causes of fatigue?
Absolutely. I find a lot of times with my patients that whenever we address other things that could be going on in their life, we're able to kind of come down to a root cause, or not, I won't say a cause, but a way to improve their fatigue without having to go straight to medications or different things like that. So I always start off my conversations with asking them, how would you describe your fatigue?
Mhm.
because there are also different types of fatigue. So we kind of addressed this a little bit, but we have the type of fatigue that just exhausts you, where you can barely get out of bed, you can barely think, you don't want to do anything, and so it affects you kind of more cognitively in that sense. But then there's also fatigue where you might just be overly tired and be more sleepy, not necessarily where your body is tired, but you're just really sleepy and wanting to sleep throughout the day. So I kind of ask about, like, do you feel like kind of coming to determine if it's more of a motor fatigue? So fatigue where as the day goes on, your body might just feel weak or heavy, or is it more of what I call a physiologic fatigue where you might feel more sleepy or more tired, or again struggle a little bit more cognitively. So once I kind of determine that, then I start asking about things like anxiety and depression. That's the thing that I feel we don't, or I don't, and I have to remind myself to talk a lot about, because anxiety or depression, especially depression, if someone is feeling depressed, you may not, that can be misconstrued as like being tired, where you just really don't want to do anything because of more of like the underlying depression. So talking about mental status and how someone is feeling from that end. So that's one secondary cause of fatigue. Another are things like vitamin levels. Low vitamin D. We're huge on vitamin D with multiple sclerosis, but we also know that low vitamin D levels can also cause some fatigue. Low vitamin B12 levels. Also, another huge thing is sleep. Are you getting adequate hours of sleep? If you're not, why aren't you getting adequate hours of sleep? And kind of having that discussion and how that is related to the fatigue or excessive daytime sleepiness throughout the day. Is there any underlying factors like sleep apnea? Is it pain? That's another thing that is bigger than we thought in the world of MS. So those are all kind of other factors that I always want to address whenever talking about fatigue.
Yeah, excellent. And then, I also, in addition, think about medications, right?
Of course.
When we treat symptoms, sometimes we make other problems worse. So if
Yes.
we're treating that spasticity, if we're treating, neuropathic pain, some of those medications that we give can be sedating. So we always have to go back and look at the medication list and see if what we're doing is causing more, again, problems than it is benefits. So it can often be very complex to kind of get down to what is the cause of it, or what fatigue we think is related directly to the MS versus what can be related to all these other things like insomnia, sleep
Right.
apnea, medications, etc.
Mhm.
So when we think about treating fatigue, I'm very interested to hear your thoughts about some recent studies that suggested that some of the medications that we use to treat fatigue aren't really as helpful as we thought.
Mhm.
Dr.
Um,
Ramahan, or
yeah.
Dr. whoever wants to go
Oh,
first.
okay. So,
Whoever wants to go first.
yeah. So one of the other thing that I want to add to what
Mhm.
you both just talked about is the bladder.
Yes.
And
Mhm.
somebody who has a neurogenic bladder, which is very common in MS, who is on the hour, by the hour, going to the bathroom, not peeing a lot, but just peeing a little, but they they are not emptying the bladder fully. They go there, they pee a little, they come back, and the urge is not gone, and they're back again. They're spending the night in the bathroom, and
Yep.
you're not going to get much sleep. And unless and until you address the bladder, where they are able to get a good night's sleep, that fatigue is not going to go away,
Mhm.
because that bladder is controlling this individual's life. And so I think it is very important sometimes, if indeed they are not emptying the bladder, to actually institute intermittent bladder self-catheterization, and make sure that it's an empty bladder when you go to bed. Might actually buy them another 2 to 3 hours of sleep or more, and make all the difference in terms of how they feel the next morning when they wake up. So, in addition to all the things, you talked about spasticity. Yes, tizanidine is a very sedating drug, and actually we like to use it during the night because it actually causes sleep. One of the big offenders is antihistamines. Uh,
Mm.
we use, I mean, how, if you, even when you don't have MS, if you take a Benadryl, how you feel
Knocks
And,
me out.
yeah,
Drugged up.
yeah, it knocks you out. And a lot of times people do not realize that when they take a tablet of Soma or over the counter medication for sleep, which people use all the time and not realize they are taking an antihistamine,
Right.
you have a problem, because
Mm.
blocking central histamine is a huge no in somebody who already has a problem of fatigue in MS. Because one of the things that I'll talk about in a minute is that histamine is a very important neurotransmitter for keeping you awake and alert, and there are many reasons for that. And so people take over the counter medications for sleep, and next morning it aggravates your fatigue 100-fold. And it is and if we can control sleep by other mechanisms,
Mhm.
it makes a difference. And
Mhm.
the other thing that I would like to mention is, Dr. Nolan just mentioned about non-pharmacological approaches to fatigue, and there was a very nice study that was done from Utah, where this is an old study, where they took patients who were severely fatigued and randomly divided them into two groups. And one group went through aerobic exercising, and the other group were told to exercise, which almost nobody did. And when you looked at the end of 6 weeks, the fatigue scores in the exercise group was so much better
Mm.
than the group that did not. So even though it'll be counterintuitive to think that exercise would make your fatigue even worse because you're already tired, it seems to actually charge up your batteries when you do exercise.
Mhm.
So you're building a certain amount of activity into your day is actually not a bad thing, actually a good thing to do.
Absolutely, and one of the things, before we talk about medications, actually, I want to go back to, talking about lifestyle modification. So when I have conversations with my patients, one of the first things that we talk about is lifestyle modifications and ways that we can combat fatigue with things like diet and exercise. And I often explain to them, some of the foods we eat can make us tired. And, what's the difference between eating a nice, healthy salad versus eating, Christmas dinner? You want to go to sleep, the other one, you might want to go for a jog. So let's talk about lifestyle modification and some of those natural, so to speak, things that people can do to combat fatigue. And you mentioned one, Dr. Ramahan, exercise. Are there any others that you all can think of?
I was actually kind of looking at different diets, and preparing for tonight a little bit. And, that's one thing that I always get asked, how should I change my diet? Is there a particular type of diet that I can do to make my fatigue better, to just make my MS better? And my response is always, we don't have any per se kind of tried and true diets, but I always say kind of heart healthy diets. But I have been seeing kind of more information about kind of like these elimination diets where you're focusing more on fruits and vegetables. And that way, just things that naturally kind of give you more energy. So incorporating those things to the diet is one thing that I've been recommending.
Anything that you would add, Dr. Ramahan?
Yeah, no, I completely agree. And I think there are a number of diets, as you well know, that are of supposedly of value. None of them really tested, but it doesn't matter as long as it's a healthy diet. At the end of the day, it can't hurt. It can help. The Terry Wahls diet, for example, is a diet that is a lot of fresh fruit and vegetables and colored fruit, which has a lot of antioxidants. And the name of her book is Save My Mitochondria. And for those of in the audience that may not be familiar with what the mitochondria is, it is the part of the cell, and in the case of the brain, the part of the nerve cell that produces energy. And in fact, one of the things that happen in multiple sclerosis is the mitochondrial degeneration that occurs that leads to premature loss of nerve cells and atrophy, which is sort of the basis of what we call as progressive disease. So there is a lot of emphasis on the mitochondria, because the mitochondria is the powerhouse of the cell, and one of the areas that is the target that of all our investigations. In fact, a lot of the current studies on progressive multiple sclerosis is looking at the mitochondria to see, if we can improve mitochondrial function. And if you look at Terry Walls, Terry Walls is and I think she's an endocrinologist, I'm not sure, from the University of Iowa, where she was severely impaired from MS and found the thing that really helped her is this diet. And of course, that's the topic of this book that she has written, Save My Mitochondria, which is she feels that consuming large amounts of antioxidants and things that are healthy for the mitochondria has made a difference for her. And today she is not in a wheelchair. She's walking about and leading a very active lifestyle. And she's a physician. And that book has got a lot of traction. And there may be some truth to it, but I'm not saying that anybody who's in a wheelchair should practice if they can find that same result if they adopt this particular diet. But there are certain types of diet that do give you more energy than others, and also may have a favorable effect on the disease as a whole. And these are healthy diets.
Yeah, and when I have the conversation, one of the things that I'm also excited about, and I actually saw Terry at CMSC, is that there is research looking at diet and its role. I think that there's so many things that, we kind of give advice about, but we don't have the research, to really back that. So I'm very excited about some of the research that's looking at certain diets as well as other interventions. I think she's looking at things like meditation and exercise, in addition to certain diets, to see how those help. And, I'm really excited to see how these interventions may help people with multiple sclerosis. But at the end of the day, of course, everybody's different. And the general advice in the, bottom line with many of the different diets is more raw, fresh foods, less processed foods. So shopping on the outside of that grocery store, getting those fresh foods. And often I've had many people who've tried a variety of different diets that kind of, focus on that have done really well in terms of improving their fatigue. So what happens, okay, let's say we're optimizing lifestyle modification. We've got someone who's as active as they can be, someone who, we're working on sleep at night, they've tried to adjust their diet, but they're still having fatigue. What do we do in those cases? Or are there any medications that can help address that? Or what's the research about the medications like stimulants that we traditionally have used to address this issue?
I would say I'll let you talk about the research, but I'll briefly talk a little bit about some of the different medications that I go off of. So there are stimulants that we try. So stimulants like methylphenidate or Adderall. There are also medications that kind of can help. I'm sorry, my dog is in the background. Medications to increase attention. So modafinil. Then there are although those types of medications are ones that I consider. Also, there is medicine that traditionally was made to be used in MS to help with walking, Ampyra. And with this medication, it's not it's used off label for this use, but I've noticed with my patients who especially complain of a lot of motor fatigue, or when they say that heat in particular affects them a lot, I'll try this medication with them. It might be it's beneficial for some of my patients. So it's definitely individualized. Again, kind of what type of fatigue are you having, and then how can we best do it. And also, when I do start these medications, I'm also making sure that I'm talking with my patients about using holidays from these medications. So what I mean by that is taking time off of it. So if you're not going anywhere, if it's the weekend and you're just relaxing at home, maybe not take the medicine so that your body doesn't kind of get used to it. So those are kind of some of the key things I talk about. and the research.
Okay.
Okay, so I think Dr. Nolan summarized it well, and I think the stimulants are the mainstay of the medications that we use, and of course, everybody knows about the 5-hour energy drink that.
Mm-hmm. It's gotten me through many an exam block, many a call night. Rockstar. They have fancy
and,
ones now.
and the
Now they're rock
Starbucks
stars
coffee.
and all
Yeah.
that stuff. But we used to just take the shots,
Yeah.
the nasty shots.
The Starbucks night, yes, indeed.
Yeah.
It has a lot of caffeine and a lot of other things in there that does it. So the reason why I got excited about fatigue is, and it is the main area of my research, and the reason why I got into this was modafinil. And when I was at Ohio State, we were using the traditional stimulants, and of course, the insurance companies were fighting us. And I was on call with a physician at the other end, and she was a pediatric pharmacologist, and so at the end of the conversation, it was we started adversarially, and then became a very collegial conversation towards the end. She approved the medication I was requesting for, and then casually she said, "Well, have you thought about modafinil as a treatment for fatigue of MS?" And I had not heard of modafinil, and it was something that was of interest for her because her area of interest was sleep, and the drug was not quite approved, but it was getting ready. It had already gone through the FDA advisory committee and was ready to be approved as a medication for narcolepsy. And so I hung up that phone call and then looked up what modafinil is, and it appeared to be an interesting compound. And when I looked at the phase 3 trial, I noticed that of all the things that it helped, vigilance, which is one of the things that you test for, which is very similar to the fatigue questionnaires that we use, vigilance was improved. So I said, hey, I should try this drug for fatigue in MS, and approached the company Cephalon, who was the company that produced the drug. And they had no interest. It was like, it's a sleep drug, and that's where it stands. And then Cephalon also had another drug in the neuromuscular field that was ready for approval. A phase 3 trial was going, and unexpectedly, it did not work out. That phase 3 trial failed. And all of a sudden, here is a one-product company. They were scrambling. And next thing I get this call saying, how quickly can you do this study that you wanted to do? And so we organized a 2-center trial. The main center was Ohio State, and the other site was Kaiser Permanente. And it was a 2-center phase 2 trial that we did. And it was incredibly, incredibly helpful in those patients. In where it worked, it was like, you gave my life back. It was all of a sudden, it was, when it worked like a charm. Otherwise, it didn't do anything. And so it was not the answer for everybody, but it certainly helped a lot of people. And you could tell in the people it worked. You didn't need to be blinded, and you could tell in whose scores it changed. So all of a sudden, from a low fatigue score, it went to the best fatigue score in these people. So we published that in the Journal of Neurology, Neurosurgery, and Psychiatry, and I was scratching my head. How does this work? How does this work? Nobody knows exactly to this day how precisely it works. But earlier on we were talking about, is there a center for fatigue in MS? And even though we say no, I say yes, there is a site, and that site is in the hypothalamus. And so think of our system in 2 large buckets. One is our fight or flight system, and that is the adrenergic part of the brain, the adrenaline type of, you all know we talk about adrenaline as the fight or flight drug. and you see a danger and you got to run, and adrenaline pours into your system, and you have unlimited energy, and you are off, and that's one system. And that's the system we rely on mostly. What is Adderall? It's an amphetamine type of drug. It's an amphetamine analog. It's a salt. And so, you take Adderall, you will be ready for fight and flight. It is that's the system in the brain that you activate.
Mhm.
And then there is the other system that is your circadian rhythm. You have the tuberomammillary nucleus, and the tuberomammillary nucleus decides whether there is a sunlight coming into your room or not. You wake up at the time when the biological clock wakes you up. And so the suprachiasmatic nucleus is your master clock. And then there are a number of other sub clocks. And when the tuberomammillary system fires, it activates. Actually, when the suprachiasmatic nucleus fires, it activates the tuberomammillary bundle. And the main chemical of the tuberomammillary bundle is histamine.
Histamine.
And the entire histamine brain is 67,000 nerve cells on either side of the brain. And that tiny, tiny, tiny part, if you think it sounds like a huge number, 67,000 is a drop in the bucket compared to the billions, that are in the brain, the large numbers. Consider we lose 100,000 nerve cells a day. Every single day, as we sit and speak, you and I and everybody in this audience is losing 100,000 nerve cells a day. And that's the rate at which we atrophy our brain, which works out to 0.1 to 0.5% of our total brain mass. So that's not something that you and I can correct. That's sadly the aging process that cannot be stopped, and that whole thing continues. But anyway, the tuberomammillary system with 67,000 nerve cells on either side secretes histamine when the master clock says wake up, and you gently wake up to the day. And that's the system we need to activate. And that's the area that I'm working on. So that's what I was talking about. Don't take antihistamines that block you, because that's adding insult to injury. When you have a system that's already messed up there, and it's not easy to increase the brain histamine. I can give you all the histamine in the world. Only thing it'll do is make you cough and sneeze, and have all the allergic things that you're used to associated with histamine. And you know how the allergic system is mediated by the histamine in the mast cells, and the histamine also mediates the acid secretion in the stomach. You have the H1 and the H2 receptors. There's also an H3 receptor in the brain. And so it's a long, complicated answer that I'm giving you, but the point is there are two systems. One is the fight and flight system, which is what we use today to combat fatigue in MS patients. It's unpleasant. You ask a patient who is taking Adderall, it increases anxiety, it increases your heart rate, it doesn't allow you to sleep. It has anorexigenic effect, which some people like. Of course, you lose weight, but so all the things associated with the drugs that we use are generally unpleasant, but it gets them through the day because they can now work with this drug. And as Dr. Nolan said, it is good to give a drug holiday, because you have this phenomenon called tachyphylaxis, which is when you keep taking the drug becomes less and less and less and less effective. And all adrenergic drugs have that problem, that as you stay on the drug, what was good today is not good a month from now. So just like she said, tell them to take it Monday through Friday. And if the Saturday and Sunday is something that you can sleep in and not really worry about the thing, don't take it. Then Monday, the drug is more effective. And these are the things. So the short answer is, I know I gave a long-winded answer, but the short answer is yes, there are these drugs that can get you through the the day. And those are the fight and flight part of the brain. And I think the drug of tomorrow is going to be drugs that increase brain histamine. And there are a number of choices that are coming our way.
So I have a question as a severe allergy sufferer, living in the South with lots of trees and pollen and all kinds of grasses. Many of my patients do take antihistamines also to deal with their allergies. So, how would that be affected, for those who need antihistamines
So
on a
do
regular
not, yeah.
basis?
So do not take an antihistamine that crosses the blood-brain barrier. So, uh, take blocking the name. The Claritin. Claritin is a good example. It'll block the histamine receptors peripherally. It has no access to the central nervous system. So there are a couple of these type of drugs that does not cross the blood-brain barrier. Those are the drugs that I would use. I would not use any of the potent antihistamines, because that's what we use to induce sleep. And in somebody who doesn't have fatigue, it's not a problem. But in somebody who has fatigue, when you take an antihistamine, and if you talk to your patients that have allergies, sadly, a lot of those patients are taking regular antihistamines because they can't do without it. Because allergy can be a huge.
I cannot. Especially in the times of COVID, whenever you sneeze, everyone is looking like, I'm like, it's my allergies, I promise. And they're like, yeah, right, it's your allergies. Yeah, so
No,
yeah.
it is true. And of course, there is also another side to it, which is the NMS. We are always trying to cause a Th2 immune response, as you know. And of course, what does the allergist do? He wants to change it from a Th2 to a Th1
To a
response.
Th1. So it
So
sounds like we
that's
need to
another
sit down with the
conflict. Yeah,
allergist and figure it out.
yeah,
Definitely.
that's another conflict
Yeah,
that
well,
BMS
thank you so
faces.
much for sharing that amazing research. So I really look forward to hearing more about that. I'm always fascinated, by this symptom that, affects so many of our patients. And, we can't seem to wrap, our brains around it in terms of, I can't point to which lesion is causing it necessarily, but we know it's affecting your daily life. And, as you mentioned, we can see it even very early on in diagnosis, because we used to think that it was just associated with the volume of lesions that you obtain over time, but it can happen very early, and it can get worse over time. So we're kind of coming up to the end of our time. And what I'd like to do is, always on Brain Chat, I love to leave people with some empowerment, something that they can do to help themselves. So what are some tips that you would give to people with MS who are dealing with fatigue, or even some questions that they, can ask their doctors, to help deal with the fatigue that they're combating and improve their quality of life?
I think the first thing is to be very mindful of your body. You know yourself and you know your body and the way that you should feel or how you want to feel better than anyone else. So making sure that even making notes of, okay, well, I'm noticing that I tend to be more fatigued during this part of the day or this time of the day, and taking all of that information with you when you go to your neurologist to go over that. That is what really helps us to formulate I guess a plan of care with how we can best help to maintain your fatigue and help you to overcome that. So that's always the biggest thing for me, is just come with a plan or go with a plan when you go to see your neurologist.
What would you say, Dr. Ramahan?
Oh, absolutely. Good healthy living is part of MS as well, and that includes a proper diet and everything in moderation, and of course getting your 8 hours of sleep, and if you're not able to get that 8 hours of sleep, try to identify the causes. Do you have problems with sleep apnea? Do you need to have a weight loss issue? Do you have a bladder problem? Are you taking medications for sleep that can actually mess up your next day, not realizing that the medicine you took tonight to get a good night's sleep also it leads you into a hangover, so to speak, the next day because you wiped out the histamine in the brain. And so everything in moderation, and exercise. Yeah. So a proper diet, good sleep, exercise. These are healthy things for anybody. And I think it should be stressed even more so in MS patients. Yeah.
Absolutely. Those are things that help MS, any chronic condition, but also help your brain. Brain health is something that we talk about a lot. And the piece of advice that I often give my patients is to listen to your body. We live in a society where we say, no pain, no gain. You just keep going till you pass out. And what I tell my patients is that if you have MS and you do that, you're going to pay for it on the back end. So if your body is telling you you need to sit down, sit down. If you need to ask for help, it's okay to ask for help, so that we rather you do a little bit every day than to do a whole lot one day and then be out of it for 4 or 5 days. So, a
And
lot of it is,
sometimes, yeah,
go ahead.
and sometimes, we need to make accommodations at work. And
Absolutely.
one of the good things that has happened because of COVID and people working out of homes is
Hmm.
something that I've heard from my patients that, you know what, I take a little nap in the afternoon, and it's,
Naps are great.
and I take that break, and it allows me to do that. Whereas when I was going to the office, I couldn't do that. But now I just basically, have a nice lunch and a little nap, and I'm a different person. And I think that's one of the pluses that has happened. And sometimes we do tell the employers that this is a real symptom and a real problem.
Mhm.
Please make an adjustment for this individual.
Mhm.
Absolutely. So takeaways are know your body. If you're not getting that sleep, let's try to get to the bottom of it with your healthcare team. Make sure you're eating a healthy diet and getting some exercise in. Ask for help if that is help with your family with home responsibilities or work accommodations, and take a nap. And with that, thank you so much for joining us for Brain Chat. I'm Dr. Missy Joy Williams. I want to thank my wonderful guests, Dr. Nolan and Dr. Ramahan, for sharing their expertise. Hope that you all learned something about how to combat fatigue with MS. And I look forward to seeing everybody in 2 weeks for our next episode. Thank you so much. And everyone have a wonderful Monday evening.
Thank you.